Good afternoon, everyone. Indo-US Chamber of Commerce of Northeast Florida welcomes you to the Wellness Weekend event. Thank you for joining us online, and I would also like to thank our viewers who will be watching the replay later. Thanks to our sponsor, First Coast Heart and Vascular Center, for sponsoring this event. This year, 2020, has been an unprecedented, stressful year for everyone. As the year comes to an end, let's get ready for a healthier 2021. It has been a great pleasure for us to put together this 2-day Wellness Weekend event just for you. We have engaged professionals who will be presenting information on heart health, women's health, acupuncture, alternative medicine, and even discuss wellness for your pet. It is my pleasure to introduce our moderator for this event, Dr. Amit Vedre. Dr. Vedre is a non-invasive cardiologist and cardiac imaging specialist. He is with the First Coast Heart and Vascular Center, our sponsor for our today's event. Dr. Vedre also serves our chamber as a director of medical programs. Please welcome Dr. Amit Vedre.
Thank you, Amita. Thank you, Indo-US Chamber of Commerce. This is a very good opportunity to talk about wellness and in general. And today we're going to be focusing on heart health wellness. Thank you again for the opportunity for a joint collaboration. On behalf of First Coast Heart and Vascular and the entire team, I would like to uh, uh, introduce our first speaker, Dr. Kristen Curry. She is our preeminent non-invasive cardiologist, well-trained and excellent backgrounds from Brown University and specifically from UMass. She joined us recently and she's going to talk about hypertension myths and salt. And without further ado, I'll give the podium to Dr. Kristen Curry. Thank you again.
Hi, thank you, Dr. Vedre. Can you hear me okay?
Yes,
Yes,
welcome.
good.
Thank you so much.
Well, thank you for inviting me to participate in the Wellness Weekend. When I was thinking about a topic, it occurred to me that I see a lot of hypertension here. Maybe half or more of my patients I see have high blood pressure. And I was puzzling over that. I didn't see quite so much, I think, in Massachusetts, and I was wondering why. And I think it has a lot to do with the stress of this year and COVID and the fact that people are isolated and people are out of their jobs. But I also noticed that there's a lot of salt in the diet here, a lot of fried foods, Chick-fil-A and chicken fried steak, and even some of the greens in the South cooking, the okra, can be very heavily salted. And I wondered if there was some relationship between salt intake and hypertension. So that was what I investigated a little bit, and that's what I'll be speaking about today. So I will wait for my slides to come up. Thank you. Okay. All right, there we go. Okay. So the first thing I thought I would address is what is blood pressure? So when your heart pumps blood through the arteries, the blood puts pressure on the artery walls. And we measure that pressure, that blood pressure, with two numbers. The first number is the systolic blood pressure. That's the top number. And that is the pressure in your arteries when your heart beats. The second number, which is the number on the bottom, is called diastolic blood pressure, and that measures the pressure in your arteries when your heart is relaxing in between beats. So what is the definition of high blood pressure or hypertension? So these are the numbers that were decided upon by the American College of Cardiology and the American Heart Association in the guideline that they published in 2017. And they have determined that a normal blood pressure is a number of 120 or less on top and 80 or less on the bottom. If the blood pressure is elevated between 120 and 130, this is called elevated blood pressure. It used to be called prehypertension, but now elevated blood pressure. Anything more than 130 or 80 is stage 1. Anything more than 140 or 90 is stage 2, and anything more than 160 or 100 is significantly elevated blood pressure. So hypertension is defined as blood pressure consistently more than 130/80. And hypertensive urgency is if that top number is higher than 180 or higher than 120 diastolic blood pressure. So the Center for Disease Control estimates that 1 out of 2 adults over age 50 has high blood pressure, very common. It's a disease of equal opportunity, men and women alike. It's a disease of getting older. By age 65, 3/4 of Americans have high blood pressure, which is a staggering number. It's more prevalent in certain ethnic groups, specifically those with African American heritage. And amongst people who are treated with medication and lifestyle modification, still many are not optimally controlled. And this is data from 2013 to 2016, so not even completely current information. And I suspect that this has only gotten worse. This is a busy slide. I just wanted to point it out because of the numbers. I mean, this is 250 million people, divided half and half, men and women. These are people who have high blood pressure. This shows that it becomes more prevalent with age, that it's more prevalent in certain ethnic groups, and that it's uncontrolled even in patients who are taking medication and who are trying to make lifestyle modifications. In many times it is still uncontrolled, difficult to control. So what are some of the common causes of hypertension? Well, certainly there's a hereditary component. High blood pressure can run in the family. It's more likely if you're overweight. And along with being overweight comes a condition called obstructive sleep apnea, which can make the blood pressure higher. If your lifestyle is sedentary or you're physically deconditioned, your blood pressure may be higher. Certainly in an environment of high stress, which this whole year of COVID has caused for all of us. Or if you're somebody who maybe has problems with anger management, you'll have a higher blood pressure. Use of any tobacco products and smoking also raises blood pressure. Drinking more than a moderate amount of alcohol. Consuming a diet high in fat, because fat and salt travel together. And then variances in metabolism of sodium, how your body processes the sodium, the salt that you eat. This is just a reminder. It's a little note about alcohol, about a serving size. A serving size is 12 ounces of beer, 5 ounces of wine, which is a small glass, or 1.5 ounces of a hard liquor. And a moderate amount of alcohol for a woman is 1 serving a day, and for men, 2 servings a day. Something to keep in mind if your blood pressure is high, how much alcohol are you consuming? Symptoms of hypertension. I will say that usually high blood pressure is not symptomatic, and that's why so many people don't know they have it. It does not become symptomatic usually until it's quite high. And then symptoms may include a headache, blurred vision, chest discomfort, chest pain, or shortness of breath. Some people will describe that they can feel their blood pressure pounding in their head. If the blood pressure is higher than 180 on top or 110 on the bottom, and you're having symptoms like chest pain or shortness of breath, that is considered a hypertensive crisis. And it is a reason to go to the emergency room and get care right away. The reason to treat high blood pressure is because over time, high blood pressure has effects on organs of the body. And these build up slowly over time, and so you want to treat blood pressure early. High blood pressure can affect your eye and cause retinopathy. It can have effects on the kidneys. But of course, as a cardiologist, what I see most often is coronary artery disease related to high blood pressure, and that's because of damage to the blood vessel, and also stroke, as well as hypertensive heart disease. So over time, high blood pressure can cause the heart muscle to thicken, and over time, it can cause the heart muscle to fail. So treating blood pressure early is important. The focus of this talk is more on lifestyle and talking with a focus on a low sodium diet. Of course, it's a whole different conversation to talk about all the different medications that are available to treat high blood pressure And that's something that we offer at First Coast Heart and Vascular. And if you have high blood pressure and you want to talk about medication, please come see us, and we'd be glad to do that. In terms of lifestyle changes, the most important thing, of course, is to stop smoking if you smoke. Maintain an ideal body weight. Try to get regular aerobic exercise every day is recommended, 30 minutes. Practicing techniques of stress reduction, whether that's meditation, yoga, prayer, and finally, eating a diet low in sodium. I'm going to make one digression, and that is to talk about ideal body weight, because so many people ask, well, what is an ideal body weight? We typically talk about body mass index, which is your weight divided by the height squared. It's not a perfect measure because it does not take into account differences in muscle mass, if you're very muscular versus if you're more fluffy. But these are the numbers we typically use to define normal body weight up to a BMI of 25, overweight, a BMI more than 25, and obese, a BMI of greater than 30. And you can measure that in your height in meters or feet in inches, kilos or pounds, but this gives a nice graphical representation.
Yeah.
So I thought I would talk about what is salt versus sodium. There is a difference. The terms are used interchangeably, but salt is sodium chloride and sodium is just sodium. So a gram of sodium is equal to 2.5 grams of salt. What you see on food labels, when you're looking at labels trying to limit the amount of sodium in your diet, they will use sodium rather than salt. So you just have to be aware that those two terms are, salt is 2 times sodium. The average daily intake in the US is 3,400 milligrams or more, and a low sodium diet refers to 2,300 milligrams or less, or we'll talk about 2 grams. And in common terms, this is about 1 teaspoon of salt per day. And if you think about that, that's very hard to achieve. Where did this recommendation come from? This comes, of course, from the World Health Organization, the US Department of Agriculture, and the Department of Health and Human Services. I've included a website if you want to look at dietary guidelines. But basically, this is the average daily dietary intake of sodium that is sufficient to meet an average adult's nutritional requirements. So where does sodium come from in the diet? And you can see the answer is primarily in processed foods, restaurant foods, processed foods. And it makes sense if you think about the fact that salt is used as a flavoring, but it's also used as a preservative. And less salt during cooking at home, of course, and adding salt at the table. And some salts occur naturally, but mostly it's what you're going to get through your choices at the supermarket or when you're eating out or in the drive-through. I think most of us know that fast foods are high in sodium. Most of us have some sense of that, even that you think that a Diet Coke beverage has some sodium in it. When you're in the supermarket and you're thinking about trying to avoid foods high in sodium, what we always say is shop around the periphery of the store, shop in the fresh foods and where the fresh produce is, and the fresh meats and dairies. In the center aisles is where you're going to find more of the processed foods. Canned foods have a lot of salt. Just as an example, a 1 cup serving of a canned soup has 30% of your recommended daily intake of sodium. A half a cup of canned peas also, lots of sodium. What we suggest in this case is if you're buying canned vegetables, to rinse and drain the vegetables before you eat them. And of course, the best option is to buy your vegetables fresh if you can. Pizza is something we all enjoy and probably eat a little bit too much. It has a lot of sodium. This is a frozen, 1 piece of frozen pizza. And then in a pizza parlor, you're probably getting even more, maybe as much as half of your recommended daily intake in 1 piece of pizza. Wow. You might think that a sandwich is a healthier option. Unfortunately, bread has salt in it, and all the things that we put on a sandwich has salt. Ham is a a particular offender, and around the holidays and Christmas time, it's appropriate to think about a 3-ounce serving is a size a little bit smaller than a deck of cards. So how many of us actually eat a serving of ham that is smaller than a size of deck of cards, and yet it contains almost half of the recommended daily amount of sodium? So if you then are making a sandwich and adding a processed cheese to that, American cheese, which is made with emulsifying salts, just one slice adds another 16%. And you've all seen how Subway makes the subs and puts lots of slices of cheese on there.
Yeah.
If you add a pickle, it's another 10%. And I didn't even bother with the chips. It's hard to get away with a low sodium diet with a sandwich and a pickle and chips. The suggestion here is try and choose a grilled chicken and try and put more vegetables on, fewer processed meats. Sauces also have a lot of sodium. Soy sauce has a lot of sodium, barbecue sauce, even tomato sauce, and salad dressings. Salad dressings, we think we're being healthy and eating a salad, and then we pour a lot of dressing on and ruin the health benefit by adding a lot of salt. So the suggestion here is to use olive oil and vinegar as an alternative. Just a word about labeling. So I picked these two at random. One frozen dinner has 660 milligrams of sodium per serving and the other 590. They're allowed to say it's a low sodium product as long as there is less than 600 milligrams of sodium per serving. So this one, even though it looks a lot like that one, can say it is a low sodium product.
Yeah.
I thought it was important also to talk about how the food industry is invested in salt. There's commercial importance to salt, and this is a little bit of a busy slide, but just focusing over here, for starters, if you eat highly salted foods on a regular basis, your taste buds are suppressed, and you habituate to salty foods. And so the more salt you eat, the more salt you crave. And the food industry knows that, and they make a profit from it. On the other side here, it's talking about the meat industry, and meat being relatively more expensive product. If salt is added to the meat, then it binds water, and it can increase the weight of the meat by as much as 20% at no cost to the industry, but at a profit when you go to buy your meat. So that turkey that you have at Thanksgiving has been injected with a saline solution to increase the weight at no cost to the manufacturer. And finally, the companies that sell you the chips also own the soda or the pop. So when you go and you buy your chips, you're going to buy a Pepsi to go with it. They're all owned by the same company, and they profit over the fact that the salty foods are going to increase thirst, and you'll then be looking to buy a soft drink with your chips. So what diet is recommended then if you have high blood pressure or if you're trying to avoid high blood pressure? The one that is most commonly recommended is called the DASH diet, and that stands for Dietary Approaches to Stop Hypertension. It's a common sense diet. It's about eating more fruits and vegetables, low-fat dairy, and limiting foods that are high in saturated fat, cholesterol, trans fats. And it promotes eating more whole grain foods, fish, chicken, legumes, and unsalted nuts. I thought I would show you the DASH trial just to make the point. This was a small trial, 400 patients over a 4-week period, and they were randomized to either have the DASH diet or a control diet, and then to eat either a low sodium diet, intermediate or medium sodium diet, or a high sodium diet. And then high blood pressure, systolic blood pressure over diastolic blood pressure is measured. So again, this is a 4-week interval, low, medium, high salt, control versus DASH. And you can see that the people with the lowest blood pressure were the patients who had the DASH diet with the low sodium intake.
Great.
The other point I wanted to make here is it's not a huge difference when you look at these numbers. It's only a few points in blood pressure gained. And so then you have to ask the question, well, if it only gains a few points in blood pressure, will that have a real difference in terms of my overall health and prevention of cardiovascular disease. So I thought I'd show you this slide, which is a trial of hypertension prevention. It's a little bit bigger study with about 3,000 patients and over a longer period of time, 10 to 15 years of follow-up. And it's looking at two populations, people who reduced their salt intake by 25% compared to a control, and looking at the cumulative incidence of cardiovascular disease, heart attack and stroke. And what it shows is that people who reduce their salt intake by 25% over a 10 to 15 year period had a 25% reduction in cardiovascular disease incidence. That is a significant number. So reducing your salt even moderately will have a real benefit in terms of reducing cardiovascular morbidity.
Yeah.
I'll make one point here. The point of this slide is that not everybody responds to salt reduction equally. People who have high blood pressure actually have more benefit from reducing salt in terms of lowering blood pressure than people with normal blood pressure. So people who have high blood pressure tend to be sensitive to salt and tend to have a greater reduction in blood pressure when they lower the salt in their diet. That gets to a concept of salt sensitivity. And without getting too technical, it's basically saying that we don't all process salt the same, that some people are more sensitive than others. And certainly people with high blood pressure, more than 50%, are sensitive to salt. And so when we make a recommendation to reduce salt, it's particularly useful for patients who have high blood pressure. And this is due to genetic predisposition. The salt sensitivity increases with age for a number of reasons. Again, it affects certain ethnic groups disproportionately. And the salt sensitivity is also increased in persons who are obese or have metabolic syndrome, including diabetes. So I can't see you anymore, so I hope you can see me, or at least see the slides.
Yeah.
Okay, I can't see you. I think I'm going to skip this slide a little bit. This gets into the mechanism for how salt raises blood pressure in the body. We can come back to it if people are interested in knowing more about it. And I think this is just a comment about when you need to see a specialist, or at least see your primary care and talk about a specialist, as if you're taking 3 medications following the lifestyle modifications and still hypertensive. That is a time to come in and talk to us about your blood pressure management.
That's great, Kristen.
Yeah, so I have a couple of just concluding slides, and that the first is to know your numbers. So check your blood pressure. Normal is here in green, so these are the numbers to keep in mind, 120/80. And make as many lifestyle changes as you can, including diet, remembering good sleep hygiene, stress reduction. And I tell my patients with high blood pressure, just get rid of the salt shaker and use some of these fresh herbs and different kinds of spices to flavor your food instead of salt.
Great. Dr. Curry, you have provided such succinct information, although we had time constraints, but amazing, well put, great points, excellently well made. In fact, we are physicians, and sometimes I can only speak for myself. I don't practice what I preach many of the times. The gram of salt and the amazing important points which you have made. The next time I'll eat my 10 or 15 chips, I'll think about it. My wife Ash was making a simple point that 10 chips can have 500 calories, literally, and so a question came across. Can you explain the difference between the top and bottom numbers of blood pressure?
Yes. So the top number, so this is the pressure exerted on the arteries by the blood when the heart beats. So you have blood in the arteries, And when the heart beats, it constricts during systole, and it generates a high blood pressure when the heart contracts, and that's called the systolic blood pressure, and that's the top number, and it's the higher number. Mm-hmm. The bottom number is what's reflected in the arteries, the vascular bed, mm-hmm. during the time that the heart is relaxing and filling. So that it's the cardiac cycle is the beating and the relaxing, and the beating and the relaxing.
Sure. Thank you so much. Another common question is, what salt is recommended for daily use?
Well, I have a slide about that because I thought it might come up, because a lot of health gurus say that Himalayan salt is better. But in fact, if you look into it, Himalayan salt has as much sodium chloride in it. So that's a myth. And it's a good way to get you to spend money, or if you like to have fancy salt, but it's not actually better for you than regular table salt. The other thought I thought might come up is not to confuse the DASH diet with the product. Of course, we all know there's a product called Mrs. Dash. And I thought it might be useful to show what the ingredients are in Mrs. Dash, because it might give you some ideas of flavors that you can use instead of salt. I say to my patients, try pepper or any of the spices that you see here on the screen to flavor your foods, including some fresh lemon juice. And again, any herbs that you can grow in your garden, or even in a pot in the windowsill, to have some fresh herbs, fresh parsley, fresh oregano. It always adds a very nice flavor to the foods.
That's so well put, because that's one of the common questions. And one of the other questions which came up from the audience was, is pink Himalayan salt better than regular ionized salt? You kind of answered that, but
I did. Unfortunately, it's not. It looks prettier and it's more expensive, but in the end, it's still salt.
Yeah. And so this is great, succinct information, Dr. Curry. Again, well put. And to kind of put some perspectives on that is, again, out of context to the current topic, but in general, imaging modalities, echocardiogram, and we at First Coast Heart and Vascular take a very detailed approach. Dr. Curry practices in St. John County, primarily in St. Augustine, and she takes great care, as you have seen through the current presentation. Wonderful topics, what you've done, Dr. Curry. This is available permanently, and as a free event, you can always log in and we can continue to share. We continue to promote the main topic, which was currently described. Any other top 3 points you would like to make, Dr. Curry, before we take it to the next presenter? Take home points, please.
Know your numbers. Know your numbers. And I guess I would add to that, it's important. People think, well, only blood pressure counts when you're sitting and you're resting and you're quiet and you're relaxed. I think it's important to pay attention to what your blood pressure is when you're running around and stuck in traffic or have a fight with your spouse, because that high blood pressure affects your heart just as well. So it's important to have good control of the blood pressure at all times, not just at rest.
Well, thank you so much, Dr. Curry. Those take-home 3 points are very well noted, and we appreciate the valuable time you gave. And again, we appreciate all the joint effort, and we wish you good rest of the day, and have a less salty day, I guess.
Thank you. Maybe I'll see you at the office. Thank you.
Thank you, Kristen.
Bye-bye.
Take it over to Dr. Kaveti, and please continue to stay over. And Dr. Kaveti is our preeminent non-invasive cardiologist. She's going to speak on women health and cardiovascular health, and primarily her background, in addition, is well trained from Morehouse, Atlanta, and New Mexico Fellowship, and she's been in the community serving Jacksonville community, Clay County, primarily, and she's served community in even Duval and Clay County and St. John's. She's here with First Coast Heart and Vascular, and without further ado, Dr. Kaveti, please take over.
Thank you, Amit, for the introduction. I'm going to talk about disease, how to recognize heart symptoms and what are the preventive measures that we can take to reduce the risk of heart disease in women. So heart disease is the number one killer, number one cause of death in men and women, but only about 56% of the women recognize this as a number one cause of death in women. We focus a lot on breast cancer, but there have been various educational activities, but awareness is still less. So apart from the traditional risk factors that are common for men and women, we also see some gender-specific, unique risk factors that affect women's health and across a lifespan. So some of the traditional risk factors that are common for men and women are being overweight, diabetes, high blood sugars, high blood pressure, as Dr. Curry mentioned, cholesterol problems, smoking, physical inactivity. But in women, the different phases of their life also impact the risk of getting heart disease in future, like the heart health during the pregnancy, weight gain during pregnancy, the hypertension or high blood pressures during pregnancy, any adverse pregnancy-related outcomes like miscarriage, small baby, small gestational diabetes, or even preeclampsia, blood pressure disorders, can increase the risk of getting cardiovascular disease in future. When we talk about menopause and postmenopause in women's health, it is a natural phase in women's lifespan. Usually women reach menopause around the age of like 50 to 54. And there is a sudden decrease in the estrogen levels in the body that brings up a lot of physiological changes that overall affects their health in future. So once women reach menopause, the risk of hypertension increases, the risk of cholesterol problems increases, and the risk of getting a heart attack increases significantly in the first 10 years of menopause. Hormone replacement therapy is beneficial, but it has shown to increase the risk of hypertension and heart disease. And it also has shown to increase the risk of cancer, like breast cancer, uterine cancer. So it is important to start the prevention way early in women's life so that we can reduce the overall risk of developing cardiovascular disease in future. The other thing is not a lot of women are aware of their heart disease symptoms. Like I'll just give you an example of a patient who came for just a pre-op clearance and for gastric bypass surgery. She mentioned like, I've been just feeling tired and I think it's because of overweight. And guess what? We did echocardiogram and we found a severe valve problem. She got a surgery for it. And within 1 month, when she came for a follow-up, she mentioned to me that I never recognized shortness of breath or fatigue as a symptom of heart disease. So it's important for us to recognize heart disease, heart symptoms early in life so that we can seek immediate medical attention. Women tend to present in a very subtle way in terms of symptoms when compared to men. That could either be lack of awareness or it's mostly because they put off their symptoms to something else. Like if a woman comes with chest pain, you think of maybe heartburn or like gallstones, but you never think of heart disease as the first cause, right? So if you notice any sort of chest pressure, heaviness in your chest, which appears with exertion, and once you rest, if the pain is going away, that is an important symptom of heart disease. The same thing applies to shortness of breath also. If you're an active person, but all of a sudden, if you have noticed a change in your exercise tolerance, like just going for a grocery shopping, it's making you feel short of breath, or just making a simple task like making a bed or getting out of the bed and going to the restroom is making you feel like extremely fatigued or short of breath, that is not due to obesity or overweight or physical inactivity. It could be due to heart disease. So when it comes to heart attack, we all quote that women present differently from men, but still chest tightness, chest discomfort is still the most common symptom. About 70 to 80% of the women still come with chest pains as a primary symptom for the heart, but they also have some other subtle presentations, like as I mentioned, extreme fatigue, shortness of breath. They may have symptoms like, jaw discomfort, chest, like back discomfort, or arm discomfort. If they are not able to localize the pain, these symptoms should be recognized as heart and they need to be investigated early. And even sleep disturbance in women associated with fatigue could be a symptom of heart disease. Breaking into cold sweats, feeling cold and clammy without a known reason could also be due to a heart attack. So understanding heart symptoms, seeking immediate medical attention is necessary. If you have any like sudden onset chest pain with any of these symptoms that I mentioned, like shortness of breath, sweating, feeling lightheaded, or feeling nauseous, call 911 because this could be a heart attack. So after recognizing your symptoms, the primary focus of this talk is well-being of women. So I'm going to talk about some of the preventive things that you can do to reduce the risk of heart disease in across the lifespan. So the simple things, like Dr. Curry emphasized a lot about DASH diet in general for hypertension prevention, but there is also a lot known for about diet in regards to preventing heart disease in women or in general. So we had a recent trial that was done, the PESCO Mediterranean diet with intermittent fasting, and the American Heart Association recommends Mediterranean diet for prevention of heart disease. So simple things like, we get a lot of questions about what kind of diet we need to follow, or is a keto diet good, or is intermittent fasting going to help me? Or simple things like, do I need to take vitamin supplements or any supplements like vitamin K to reduce my risk of heart disease? The answer to that is eating a balanced diet where you get these nutrients from the diet itself. So based on the research, we have known that the Mediterranean diet works. The Mediterranean diet is a plant-rich diet, which is rich in nuts, fruits, seafood. Extra virgin olive oil is recommended for cooking, which is the source of fat. And fish and seafood gives you the source of, like, it's a good source for omega-3 fatty acids, vitamins. So the usual recommendation is eating at least 2 servings of fish or seafood in a week and avoiding red meat as much as possible. So again, avoiding preserved food, which has excessive salt in it, limiting the salt in diet, or avoiding added sugars that will help in reducing your overall risk factors for heart disease. Like it helps in maintaining good blood pressure, it helps in maintaining good blood sugar levels, reduces inflammation in the body, which overall reduces the risk of getting a heart disease in future. The other thing that is important is snacking in between the meals, and also paying attention to the portion size. So if you are in the habit of like snacking in between, go for nuts, which are healthy. Go for like carrots or celery, which is not going to affect you much. It has less carbs, less fat, and pay attention to the portion size. Like really, before you go to the second serve, just question yourself, like, do I really need the second serve or not? And take time to eat. Like, I mean, in this fast world, we don't have time to like set aside to eat. Like we usually work and eat at the same time. And during that time, we don't know how much we are eating or what we are eating. So make sure like you eat slowly, take small bites, and practice like mindful eating. And again, when it comes to like coffee or any beverages, I usually ask my patients to avoid soda as much as they can and substitute it with water. Because we do get questions about alcohol, moderate amount of alcohol is it's still protective. Like, red wine is considered protective for preventing heart disease, but limiting the amount, like limiting it to just 1 drink a day, is important. So talking about intermittent fasting, it's about like, it is trying to get your daily intakes of calorie within a set window of time, like within the 6 to 12 hours each day. And after that, not eating anything. that has shown in weight loss and also shown in reducing heart disease. So this is something I would recommend. Whatever you do, take it slow so that it becomes a part of your life instead of like you going on a crash diet and losing weight. Just try to make it a part of your life. Coming to the next preventive strategy is exercise. We all are busy. We may not have enough time set aside for exercise in general. But there have been studies and recommendations about exercise activity. American Heart Association recommends 30 minutes of moderate intensity activity every day or 150 minutes of activity per week. The question is like, how do we get that exercise during our daily routine, or how do we set aside the time, or what kind of exercise do we do? So like, start with like, setting up realistic goals. I would say like, you're so busy that you don't have time for exercise. Try like when you're taking stairs, 1 or 2 stairs, take stairs instead of using the elevators. Count your number of steps. You can set a target of 4,000 steps to begin with per day, and then slowly increase it to about 10,000 steps a day. Yeah. Do something that you like. If you like going for a walk or running, jogging, or if you like to go to a gym, do that. Like, you don't need to force yourself to do anything, because you're not going to continue that. So find an activity that you like. I mean, I have patients who say that they can't exercise because of arthritis problems, but there are other ways. Like if you discuss with your doctor, we can set you up with a physical therapist or send you to a rehab where they can give you an exercise prescription that is tailored to you. Like, you can do water aerobics if you have knee arthritis or hip arthritis. So something that will not cause much pain. You don't have to take much time, but you can make it like a part of your life. And again, what I have noticed is if you have a friend or for someone who can do that with you, like a gym partner or like a walking partner, I mean, you stay more activated and you can motivate each other. And stick to the schedule. Like, timing is important. If you're not able to get 30 minutes every day, try to get like 45 minutes 3 times a week, or an hour workout on the weekends, so that you get your 150 minutes per week. So coming to the other physical inactivity, even physical inactivity like sitting in one place for hours, more than 3 hours, is considered a risk factor for heart disease, just like diabetes, asthma. So to break that cycle, if you like, a lot of us are now doing work in front of computers. Even kids now are doing virtual school. So it's very important to remember that, you need to get out of your chair, walk for a few minutes, and break that cycle of physical inactivity. So I tell my patients, if you're sitting for 3 hours, get up and walk for 15 minutes. It's a simple thing that we can do if it's a busy day, and if you get a call, answer the call, but walk while you're answering the call. So simple, basic things. Sleep also plays a very important role in the overall well-being. It is recommended that we get 7 hours of sleep. Like, tell me, Amit, do you get 7 hours of sleep? Not really. So it's important for us to, like, the time that we sleep, it should be peaceful. Our brain should be rested. So maintain a sleep hygiene, like go to sleep at the same time and wake up at the same time. Avoid taking long naps. Avoid using stimulants like coffee close to bedtime. Minimize motion at night, or minimize any interruptions during the sleep. Okay, and the fourth most important preventive strategy, which is common for everyone these days, is stress.
Yeah.
So there's stress at work, there's stress at home, and not everyone is good at managing their stress. But stress is a known cardiac risk factor. The reason is when people are not able to cope up with the stress, they get into this poor behavioral habits like overeating, eating the wrong food. Stress also sets in depression that leads to like lack of activity, physical inactivity, obesity. So it's important to manage stress so that we can avoid developing these poor habits. What I would suggest is like if you're stressed out, just take a break, go for a walk, or just isolate yourself for 5 minutes. If the work has been overwhelming, make sure you take time off and have like a complete contrast change during that time off.
Yeah.
Which is again a difficult thing to do. This last year has been challenging for many of us due to the COVID situation, especially kids working from home. Most of us working from home, where you don't have like a good like separation between your office work and your personal life. Like it's just like a continuation.
Yeah.
So taking time off is so that it gives you an opportunity to relieve your stress. And again, on a day-to-day basis also, when you come home, find something that makes you happy. Like in my case, I have my 2 little kids. As soon as I come home, I see my kids, I play games with them, I paint with them. So that is a huge stress buster for me. So
that's lovely.
Yes, you have to just find something that's going to make you feel happy and make you forget the work stress. Exercise is, again, also a stress buster. So if you, like, when you're sitting in front of a desk, it's more of mental exhaustion, not physical. But if you're stressed out, just go for a walk. That will help in, like, you can release stress, and it's also good for your overall health. Because, like when you exercise, the body releases endorphins, which make you feel happy. And again, if it is overwhelming, instead of developing bad behavioral habits, or going for excessive smoking or eating habits, ask for help. Like you can talk to a friend about the stress, talk to someone, or talk to your doctor so that they can set you up with a counselor or with a psychologist who can help with managing the stress levels. So
no, that's wonderful. Yeah. So Dr. Kaveti, you've done such remarkable accumulation of main points. Pretty soon we'll ask a few questions from the Facebook and live audience. There are some key points which you've in detail mentioned so well, like symptoms, how women present differently than men. I think that was a very glaring point. I do believe that's one take-home message we all as a community should understand. What Dr. Kaveti just mentioned is women present very differently than men for heart disease. So important point is recognition of these points and attempting to identify preventive strategies. And one of the most important point I took is de-stress mechanisms, attempting to get your, if I interpreted it correctly, getting some me time, right? In between your time, just have some me time, and it removes the catecholamine surge, if you will, and it has been linked to hypertension, relieving of the pressure and things like that. So Dr. Kaveti, soon we shall start asking you some very basic questions, and then you can end perhaps with top take-home 3 messages. So one question I have is, and the community is asking is, if you can elaborate how women present differently than men, like 2 points for heart disease.
So again, they do present with the same common symptoms like chest pain, but they may not recognize that it is coming from their heart. So they kind of like wait till they start noticing other symptoms like extreme fatigue, lack of sleep. They may have wake symptoms like nausea, vomiting, or shortness of breath, which again, they may attribute it to like different reasons like physical deconditioning, obesity, or just lack of energy.
Do you think in general, is there any specific imaging modality or in general, what studies can be done and in women or in men in general too, but in heart disease, what would you say are the main studies?
So if you do have these symptoms, and especially if you have like a family history of heart disease and you do have subtle heart symptoms, definitely talk to your primary care doctor so that I can refer you to a cardiologist. And what I usually start with is a simple exercise treadmill test. Like if they have a absolutely normal EKG and if they exercise, because that gives us a lot of information, right? Like like whether the fatigue is due to physical deconditioning or whether there is really underlying heart disease, we can just answer that with a 15 minutes of stress test. The other test I would do is getting an echocardiogram. If it is all about risk stratification, like if the question is, do I have buildup in my heart arteries? Do I have coronary artery disease, or what is my risk of getting a heart attack? I would just do a simple CT scan, coronary calcium score,
Sure.
Which gives us immense information. Like it helps us in starting them on medications that are preventive, like medicines. Statins are the only medication that has shown to reduce the overall risk of getting a heart disease in the future. So both men as well as women. So if we do a CT and we find cholesterol plaque or calcium, I would discuss statin therapy with my patient and start them on. Echocardiogram is another imaging modality that we use commonly in cardiology. It gives us information about the structure of the heart. It tells us how the valve function is. It tells us about the pressures inside the heart, and it will help us find out if the patient's symptoms are related to any of this heart-related problem.
Excellent. So, in general, our audience are so more of non-medical, and I'll ask a question in general. One of the question came, it's a more or less a medical question, but I do believe it's a strong question. Is one of the audience member asked, what is Takotsubo cardiomyopathy? She heard about it and she's perhaps worried about it. And is it more in women? Perhaps you can talk more with your patients in the clinic. And again, to remind, Dr. Kaveti is in the Clay County and she's an excellent based non-invasive cardiologist, but she'll tell a little bit about that.
So Takotsubo cardiomyopathy, it's a stress-induced cardiomyopathy. So when we talk about the heart function, the squeezing function of the heart is supposed to be more than 55%. But when there is a stress event, there is a sudden surge in the catecholamines, in the adrenaline. Like maybe we don't even understand Takotsubo cardiomyopathy that well, but because of all these, because of the sudden stress event, there is a rapid drop in the heart function. Like the heart function can go down as low as 20% or 30%. So that is called Takotsubo cardiomyopathy. And again, it all depends on how someone manages their stress.
Correct. Great. And yeah, the take-home message we are getting across the board from what you've been telling us, Dr. Kaveti, is stress is the hidden risk factor, not necessarily family genetics, in addition to high cholesterol, diabetes. I think stress is a hidden risk factor. A question just came up. Is there any particular exercise modality, or what is the thing which you would ask for everyday healthy lifestyle? I guess it could be worded, I suppose. Is there any one thing you would ask us to do as a audience to limit heart disease and reduce the heart disease, Dr. Kaveti?
So we usually talk about lifestyle modification as a package. So which includes like diet, exercise, and sleep. So one thing is about, I think I would start with exercise. Because when I say like moderate intensity exercise, it can be anything. It can be swimming, it can be dancing, it can be running, jogging, or walking on a trail. Anything that you like. But when you say moderate intensity, that means it's to an extent where we're not able to talk in full sentences. So the intensity is more. So if there's anything that you want to make it as a part of your life, I would start with taking stairs every day, walking as much as you can,
Great.
And avoiding sitting in one place for hours.
Wonderful. A question just came up, which is, I think, a very important question is, what would you say, or what would you recommend? I guess I'll read the question verbatim. Are you able to hear me okay, Dr. Kaveti? Yeah.
Yes.
Please discuss daily intake of water for patients who need a diuretic. In other words, this question is from a very well-known, preeminent person who is an echo for womenheart.org, and she promotes it and she does a great job at that, and we'll talk more. But fluid intake, when fluid retention is a problem. But in general, do we have any daily intake of water for patients, please?
In general, for the overall well-being in any normal individual, we recommend at least 8 glasses of water per day. But there are certain heart conditions that can predispose you to water retention. Not just heart, there could be liver or kidney issues too, where your body tends to hold on to water, and that fluid starts to get into your lungs or your belly or your legs, causing various symptoms like shortness of breath. So when we prescribe diuretics, which is a water pill, our intention is to get rid of the extra fluid and at the same time maintain the blood volume. So if you see a person who is has 20 pounds of extra fluid in them, definitely you ask them to restrict the water to less than 2 liters and take diuretics. But if you only have a patient who is dry, but you're giving them the medication just to maintain, then you don't need to restrict the water. Even heart failure guidelines, when you read, they say you restrict the fluid intake when the sodium level is less than 135.
Sure.
So listen to your body. If you're thirsty, just drink small sips of water, take ice chips, but don't drink sodas. And when we talk about fluid intake, we are talking about overall fluids, not just water. We're talking about caffeine. We're talking about sodas. We're talking about alcohol or anything that they take in a day. Try to get to less than 2 liters.
Maybe 1 or 2 more questions. I think we are well within the time, Dr. Kaveti. You've covered very well at more or less like a town hall question-A format. A question came up is, I know everyone has stress, but what is the one thing which you would follow daily to manage it better? Are there any thoughts in that perspective?
So one thing I manage better is I keep my personal life very different from my professional life. I'm a completely different person when I come home, and I'm a completely different person when I go to the hospital or clinic. Because it's when I'm in the car driving to work, I think about my hospital patients, my clinic. But when I'm driving home, all I think about is my family, my kids. So maintaining that contrast, keeping the 2 things separate will help in managing stress. And of course, when it is overwhelming, I definitely talk to someone. I talk to my husband, my friends, or my family, and talk to them about it so that I can relieve myself.
Great. A question came up again, which probably is directed towards the first Dr. Curry. What is a safe amount of salt intake to prevent heart disease? Primarily, I think 2 grams, and she dealt in detail. And I would like to remind the audience that all of this are recorded and will always be permanently available. And Dr. Curry in detail mentioned in detail about, so they're always available. Great questions, great format. We love the information so far. We'll leave a couple more minutes. The YouTube, Facebook, and Instagram have been posting a lot of questions, and we love the enthusiasm, how this has been going. We love the communication from how the Indo-US Chamber of Commerce, Northeast Florida, in collaboration with us, has taken a good step towards the in general communities of Duval, St. John's, Clay counties. In general, would you say in your topic today, Dr. Kaveti, what are the 2 top points in general we can take home, and what would you like to stress on, please?
So I would stress more on prevention of heart disease, and also understanding the symptoms of heart disease so that you can get to the specialist who can manage it well.
Great. Yeah. So, well, that's it for Dr. Kaveti. Community, you've done. Thank you so much. Dr. Kaveti is our, again, preeminent non-invasive cardiologist in our Clay County. She's always available, and she's so approachable. We love the time you gave us, Dr. Kaveti, and thank you so much for your time today. And we'll bring in our next speaker soon. And anything else you would like to add, Dr. Kaveti, before we move on?
I think I want to thank Amit and of course Indo-US Chamber of Commerce for giving me the opportunity to talk about women's health. And of course, I am in Clay County. I have my office at US 17 Fleming Island. So if you think that you need an expert consultation, or if you're concerned about your symptoms, please reach out to us. Of course, if you have any questions, post it on Facebook, and I'll answer.
Great.
Thank you.
Yeah, thank you so much. So team, let's move on to Dr. Pabi. I'll speak about Dr. Pabi. Dr. Pabi is our, for me, I would say, guru. Dr. Pabi, welcome, sir.
Thank you, sir. I listened to your last few minutes, and that was excellent job by Dr. Vidre. Very well done. I think very well moderated and to the point, and Dr. Kaveti did very, very well. And I think the questions which were asked were really, really to the point and very well to the topic.
Great. So community and all our patients, lot of interest is being generated. And now, of course, Dr. Pabi is coming. So we will have even more, I would say, in general, just as a joke. But so a little bit of background about Dr. Pabi, everybody, is Dr. Pabi is our senior most electrophysiologist with us, who is not only an internist, a cardiologist, but a very, very highly trained electrophysiologist who deals with pacemakers, irregular heart rate, atrial fibrillation, defibrillators. But more than anything, he is a holistic who sees the patient as one and identifies the main root problem instead of a specific problem. And he's trained in the background from highly premier medical schools from India, and trained in Aurora, which is one of the foremost genesis of electrophysiology gurus, I would say. So without further ado, sir, Dr. Pabi, let's go through your topic, and we'll discuss through your topic, and we'll ask audience questions in between, and we'll go through that. Welcome, Dr. Pabi.
Thank you very much for the introduction. I mean, that was very appreciative. Like Amit said, the cardiology has been my passion for a long time, and I did practice internal medicine as primary care for a long time as well. That gave me an experience as well as an attitude that you can't focus on one problem at a time. If somebody's coming in with not feeling well, you got to look at the patient overall and got to the bottom of it and see what's going on. From internal medicine, I practiced cardiology and then went to do the electrophysiology, which has been my passion for a long time. As Amit said, the electrophysiology is a branch of cardiology, super specialized in just dealing with the electrical circuits of the heart. And just like you have at home, the plumbing electrician is basically, a nutshell, called the electrician of the heart. Mm-hmm. I'm going to talk about a topic which is very dear to my heart. The two topics which I'm very fond of, one is the sudden cardiac death and one is the atrial fibrillation. Today, for the public's sake, we're going to talk about atrial fibrillation. Atrial fibrillation, the name sounds very long, but it is atrial, like A-T-R-I-A-L, atrial, and fibrillation. Atrial fibrillation is one of the most common arrhythmia in the United States, and not just in the United States, it is the most common arrhythmia actually in the whole wide world. 200,000 of cases of atrial fibrillation happen every year just in the United States. 30% of the people above age 60 or 65, and 40% above the age of 75 will have AFib, in short form atrial fibrillation, we call AFib, will happen during the lifetime. So somebody may say, I have never heard of AFib. I never heard of this irregular heartbeat. What the heck is it? What does this atrial fibrillation mean?
Yeah.
You may have talked about the patients coming in or talking to their friend and say, hey, I've got an irregular heartbeat, or my heart doesn't feel right, or it flip-flops, or it just, I don't feel right, and my doctor told me I've got arrhythmia. A lot of people have different versions of AFib, but the atrial fibrillation is basically the irregular heartbeat of the top chamber of your heart. Normally, the upper chamber squeezes this and the bottom chamber picks up.
Yeah.
In AFib, instead of beating from the top chamber like this, your top chamber starts to quiver.
Yeah.
So you're basically quivering in the top chamber of your heart, which leads to the pooling of the blood in the top chamber, and the upper chamber doesn't pump down to the lower chamber as much. So many people may actually feel very different symptoms. People say, hey, I never felt it. But if you're saying it is such a common arrhythmia, 30% people above the age of 65, 40% above the 75 have it, how come I don't feel it? Now, your interesting question is, 1/3 of the people who have this arrhythmia may not feel any symptoms.
Wow.
So, which is very bizarre, because what will happen is people will come for let's say they're going to go for surgery or they're going to go for some operation, and they come in and have their EKG done in the doctor's office, and doctors look at the EKG and say, oh my God, your heart rhythm is not in rhythm. It's not in sync. You are out of rhythm in your heart. You got to go see your cardiologist, or you got to do this. And that's what sometimes the atrial fibrillation will present, because 1/3 of the people have no idea that they're in AFib.
So asymptomatic.
Asymptomatic, like completely like they're going in the ball, ready to going to the baseball game or going to the grandkids' birthday parties and stuff, and they don't know.
Wow.
But the problem is that 70% people will have symptom, and the most common dreaded symptoms which we worry about, or the complication that can happen from AFib, is the stroke.
Yeah.
And I'll come to that in a second. But people would ask me, what symptoms do I feel? What 2/3 of the people will have the symptoms? So symptoms of AFib may include palpitations, where somebody may be sitting and say, hey, I suddenly start to feel my heart racing. I feel it jumping out of my chest. I feel like I'm doing well. I'm just sitting there. All of a sudden, my heart starts to beat funny. I feel like a fish flip-flopping in the chest. I may feel lightheaded. I may feel dizzy. Some people feel short of breath. Some people may feel chest pain with it. Some people may just feel tired when they're in AFib. So a lot of variety of symptoms the AFib can produce. And unless you're keeping an eye on these symptoms, you may not even think about these things, that this is what's going on.
Wow.
And now the question comes is, hey, listen, what if my just flip-flop? Do I really need to worry about it? What can the AFib do to me? Why am I so gonna be concerned about this?
Yeah.
The main thing which we gotta worry about the AFib is the atrial fibrillation can increase your risk of stroke by 5 times. So what I mean is, if somebody my age, Dr. Vidre, let's say, he's younger than me, but I'll give him a credit. So let's say he's my age and he's healthy looking guy, looks pretty sharp, and I am a little overweight and I got AFib.
Yeah.
Now, my risk of stroke goes up 5 times right away when I'm in AFib, whether I'm in AFib or not AFib. But if I have a history of AFib, my stroke risk goes up by 5 times right away. That's where the whole concern comes in. 20% of the strokes which happen in the United States.
Yeah.
Stroke means people may come up with the paralysis, their arm not working, or they have a slurred speech, or they're not able to work, or functionality goes down. 20 to 30% of the stroke happening in the United States are just happening because of atrial fibrillation.
Yeah.
Atrial fibrillation is an arrhythmia which can be easily treatable, diagnosed, and the treatment can be given for that reason. So at least that way people are not at a high risk of stroke. That's our main concern with the atrial fibrillation, is we don't want people to end up having a stroke.
That's
somebody's playing a baseball, somebody's going and doing their activity, somebody's a factory worker going to their office.
Yeah.
And nothing you know, they didn't realize, or they have some irregular heartbeat, but they end up with a stroke, and that just jeopardizes their whole rest of their life. they are disabled.
Mm-hmm.
That's exactly what we're trying to avoid.
So I think that's a very initial important point you've mentioned, Dr. Pabbi. Can you elaborate on, so you've mentioned about symptoms, varied symptoms, and you mentioned, is there any age restriction or is there any particular age to expect it?
Yes. So like I said, the atrial fibrillation is the most common arrhythmia, not only in the United States, but in the world. 30% people above the age of 65. So
Okay.
AFib is the arrhythmia of the aging. More you age, just like you get cataracts, just like you get arthritis, just like you get gray hair, or for me, say, just like you lose hair. The same way for AFib, the more you age, more likely you're going to have the AFib.
Okay.
So 30% above the age of 65, 40% above the age of 75 in their lifetime will have AFib. Whether the AFib can come and go or it stays there, that depends on the AFib. Now, that doesn't mean the young people can't have it.
Okay.
The older you are, more likely you're going to have it. And more older you are, more likely you're going to have a stroke. So it's even more critical that the older people gets the treatment on a very regular basis and be on the blood thinners. And we'll talk about that in a few minutes. But that doesn't mean the young peoples can't have it. I have treated the patient, even a 21-year-old kid with the AFib, 31-year-old with the AFib, 35-year-old with the AFib. One of the more common trigger factor in the young people is the alcohol. Now, I jumped the topic a little bit, but alcohol is one of the very, very common trigger factors, especially in the young and in middle age for atrial fibrillation. Alcohol is very directly related. In the old times, the coal miners who used to work out in the mines in Philadelphia, Pennsylvania, all those places, there was a study which showed that when they come home after on the weekend, everybody was having party, drinking alcohol, and on a Monday, everybody will be in the AFib. And the same thing we see that after Christmas and after Thanksgiving, because people end up having a little bit more alcohol than usual. I'm not talking about too much, but I mean, sometimes even the binge drinking, a couple of drinks here and there, if they're not used to, that can put people back into AFib. And we used to call that a holiday heart syndrome, that people on the holidays have a little bit of a few drinks, a little cherry Mary, and they're in AFib. But the reason for the AFib, like I said, you're concerned is you got to talk to your physician, you got to get some help, because this is very easily treatable condition that will help to prevent the stroke.
Okay. How do we diagnose AFib, Dr. Pabbi?
So, like I said, to keep an eye on the symptoms, you got to watch and feel that whether you're having irregular heartbeat, whether you feel like your pulse is irregular, you feel short-winded, you can't get enough air. The things you could do before, like exercise, or you could go, let's say, go around Walmart or go around shopping, and now you can't do that. You start feeling swelling in the ankle. Those are the sign symptoms to watch for. If you feel any of those things, you go get some help. Talk to your physicians, even your primary care physician. They can do an EKG, just an ECG. You call it EKG or ECG. That will be able to tell you whether you're in atrial fibrillation or not. And once you have an atrial fibrillation on the EKG, then you need to get either talk to the primary care or talk to the specialist, and then they'll start the treatment appropriately.
Okay.
Now, many times, like I mentioned, the AFib can come and go. You have this AFib, or you don't have an AFib. So sometimes people may have it today for 15 minutes, and then they don't have it. They have it, they don't have it.
Okay.
Your primary care may ask you, or a cardiologist may ask you to put a 24-hour monitor, and sometimes even a 30-day monitor, and that will be able to help them diagnose the atrial fibrillation. Sometimes we put a little chip under the skin called the loop recorder. If we suspect the suspicion of the AFib is higher, and that can help with us too. Sometimes people will just present with a stroke. They have no symptom at all. In the hospital, they'll come and they'll have a stroke. And we go back and try to find out if there's anything else going on. And if we can't find an answer, sometimes we put a little chip, like we said, the loop recorder or the 30-day event monitors to diagnose that.
Identify. Okay. Although it is a little out of the loop, but a quick question came along, which probably is pertinent here, Dr. Pabbi. A question came up from the audience which says, how can you get checked for AFib without going to an ER if the patient is away from the ER and is getting a full workup? Is there any specific diagnostic modality or something, a tool in the house or something?
Absolutely. It's a new technology. I think that if people are, so the whole purpose for this talk today is that we make people aware.
Yes, sir.
Atrial fibrillation is a condition and you got to watch out for that. If we can do that, that serves our purpose. Now, it's a very good question saying if you're not available or you can't go to emergency room and it's a weekend and or you have no access to the physicians or they can't see you, how can you diagnose AFib by yourself? Now, there are a couple modalities which are available now which can help us. I mean, these days, even the regular blood pressure cuff, which you can buy for $20 on the Walmart, Walgreens, Publix, anywhere else. Many of those ones, when they give you the blood pressure, they give you the pulse as well, which tells you what your heartbeat is. And sometimes they have a flashing heart sign. That flashing heart sign sometimes can give you a broken heart in the middle.
Yes.
So sometimes instead of regular heart beating, it'll give an arrow in the middle or something, which can suggest that something is not right. That means you got to look for some help. Other thing these days, which has come out as a new thing, is the Apple 5 watch. So Apple Watch with the 5th generation that can detect your EKG and tell you whether you're an AFib or not. It's a very new technology. It's very, very good algorithm we have defined, and it's been very well verified, where you just hold the button and it'll do that EKG for you 20 minutes. It won't tell you if there's anything else or not, but it can definitely tell you if it is atrial fibrillation or not. Similarly, there's another app called the Kardia with Kardia. Costs about $90, $100. You can get that. That sits on your phone. You put your fingers on it and it can take the EKG and can tell you whether this is AFib or not. Like I said, it will not tell you if you're having a heart attack. It will not tell you if you're having chest pain, that's EKG is abnormal or not, but only thing it can detect is whether this is atrial fibrillation or not.
Great. A pertinent question came up from one of the audience. Are palpitations the same as AFib?
Yes, a very nice question. So palpitations and atrial fibrillation. So palpitation is a very general term we define where somebody feels the palpitations or the beating of the heart. Now, palpitations can be multiple things. Palpitation is a very general term we use where your heart may be beating fast or maybe skipping a beat or could be flip-flopping or could be the pounding heartbeat. All palpitation does not have to be AFib, but AFib can present with some palpitations as well. What that means is AFib can present as some irregular heartbeat, can give you the flutters in your chest, can give you the flip-flop, but that can get people to feel palpitation. But palpitations can be AFib or does not have to be AFib, but it could be very different, different arrhythmias as well.
Okay. What would you say, since we talked about symptoms, presentations, and the modalities, and we have raised the awareness, and that is the most important point. Although it is a huge topic by itself, what are the main treatment modalities, Dr. Pabbi?
Absolutely. So now the question comes is, hey, I diagnosed with atrial fibrillation. Let me just go a little bit more detail and a little bit on one more topic. I mean, so AFib, like I mentioned back and forth, people can have AFib and they may not have AFib the next day. They may have AFib today, they may not have AFib tomorrow. So AFib is defined in 3 different categories. We defined it as a paroxysmal AFib, where you have AFib today, may not have it tomorrow, may have it for an hour, may not have it. Then it is defined as a persistent, which would mean you've been staying in AFib for 30 days or longer. And then there is a chronic where people stay in AFib all the time. And the reason I said that define is because sometimes we may define some of our treatment plans based on those things. The main thing, like I mentioned, I want to make sure you don't end up with a stroke. That's my main priority. So first priority is to protect people from the stroke. So when people come in, when somebody walks into the office, we assess them. we assess them with certain risk factors. We call CHAD-VASC2 score, CHADVASC2, CHAD-VASC2. Basically, everybody, male or female, we assess them and see what kind of risk factors they have, whether they have any heart problems, whether they have any kidney problems, whether they have a high blood pressure, whether they have a diabetes, what's their age like. That gives a score to us. Anybody with a score of 1 or higher needs to be on a blood thinners.
Okay.
Now, blood thinners, we are talking about, you see the commercials on the TV, Coumadin, Pradaxa, Xarelto, Eliquis, there's a different kinds, not just the aspirin. People think I'll take an aspirin, I'll be okay. Those you need to be on a stronger blood thinners, and that will help you to protect from stroke. Basically, what those blood thinners do, they don't fix the AFib. All they do is they thin the blood. So when you go into AFib, the blood stays thin. The blood which is pooling there, when the blood is the urine AFib, the heart is quivering. It doesn't let it form a blood clot.
Okay.
So when the blood keeps thin enough, they keep it away from forming a clot, and it protects you from a stroke. That's one strategy. The second strategy becomes is, if you feel bad, let's say, hey, doc, I don't feel good at all when I'm in AFib. I feel chest pain. I feel short of breath. I can't do anything. I have to lay in a bed for all this time. What can I do to make it feel better? So in that cases, we have different modalities which we do. We use certain medications called beta blockers or calcium channel blockers to help slow down the heart rate and try to put you back in rhythm. And or we use certain stronger medication which can help to control this irregular heartbeat and not let it go into irregular heartbeat at all. And sometimes if people are staying in irregular heartbeat and medications are not helping, sometimes we shock them. That we do what we call the cardioversion, where you see that in the movies where put the people the paddles on and they say, hey, clear, that kind of stuff. That helps to reset the electrical condition, put them back in rhythm. And then there are multiple procedures we can do as a very subspecialist, where I can go from minimally invasive procedures where we can just go through the groin, through the vein, through the IV kind of stuff, and go to the heart, find the short circuits, and we can fix it. And basically, we can actually help cure the AFib as well in a long term.
That's very well put, Dr. Pabbi. A question came up: how do we reduce the risk of AFib? My family members have it. How can I reduce my risk? What would you say?
That's a very, very great question. Remember, I said that the atrial fibrillation, it gets worse with the age. Just like people get arthritis, people get cataracts, people get gray hair, that you're going to get AFib. And it's just a matter of arrhythmias, is a matter of aging. It's just going to happen. Now, what can we do to help prevent it? Younger population, obviously, maintain a healthy lifestyle. Stay away from too much caffeinated products.
Okay.
You can have a coffee, you can have a tea, but stay away from the energy drinks. Stay away from too much stimulants, anything decongestants. Even in a certain medications, people say, hey, I don't drink any coffee, I don't drink any Mountain Dew, but I take 5 Sudafeds a day and I take decongestant, this for that thing. So anything in moderation is okay. Same thing with alcohol. People may say, I drink. I don't want to say people not to have it. Some people say red wine is good for your heart, but anything in moderation is okay. But anything in excessive or binge is not the best thing. So yes, stay away from stimulants, whether it is the over-the-counter medications, whether it is the stimulants to lose weight, whether it is the energy drinks, whether it is alcohol, whether it is caffeine. Anything in moderation is okay. Avoid excessive use. Exercise every day. The more exercise you do, your healthy lifestyle, it is good for you. Keep the weight under control. Body mass index of less than 25 is considered a healthy. And I'm pretty sure Dr. Kamadi or Dr. Curry must have addressed that weight loss.
Yes, sir.
And, avoid too much salt. And especially if it is the South, the Asians, we have to watch out because we get our obesity and everything around the waist. So watch your carbohydrate intake, exercise on a regular basis, and that would be my suggestion to prevent the AFib.
Great. A question has come up which is pertinent, although it is a little bit more elaborate. My father has AFib. He's on medicines. He's also on a blood thinner. He keeps having multiple episodes. What is ablation, and do you do it, and where do you do it?
Absolutely. So it's a great question. This is exactly my subspecialty is the electrophysiology. And like I said, I only deal with the electrical circuits. So people who having continues to have AFib episodes despite being on the medications, and or the young people, let's say somebody is 36, 40 years old, 50 years old, and they diagnose with AFib and they keep on having the episode, they say, I don't want to take the pill for the rest of my life. You got to take, because once you're on the medication, it's hard for these ones to stop. These are stronger pills. Or they're having side effects with medication. And in those cases, ablation is a very reasonable choice. Ablation stands for ABLATION. Ablation is a procedure which is very minimally invasive. It takes me about an hour and a half to 2 hours on the average to do that. People go home the same day. And basically, there's a procedure done in the hospital. We go through the groin area into the vein, and then we cross over into the right side from the left side of the heart. Atrial fibrillation starts from the left upper chamber of your heart. We call them 4 pulmonary veins. And we basically go and isolate those veins. What that means is we go and find those short circuits for AFib, and either we can freeze them with the liquid nitrogen, or we can heat them or cauterize them, so that way the AFib cannot come out and can keep people back in rhythm.
Okay.
Successful procedure. It has evolved a lot. It started about in 1996 or so, and it has been definitely, the technology has changed. Once we're done with this procedure, especially, the data is very clear. If we can get this procedure ablation done with people with AFib in the first year of the diagnosis, some people can be cured of this AFib. There's 65 to 75% chance that they will not even have any AFib for the rest of their life. They're done, they're cured. And some people may need a second one that improves the success rate to 80%, that they won't even have any more AFib.
Okay.
Procedure complication rate is less than 1% to 1.5%. And like I said, if we do that in the morning, most people will go home in the evening and carry on with their normal lives.
That's wonderful. And where do you do these procedures, Dr. Pabbi?
Yes, so I have done multiple of this procedure. I do 2 to 4 a week of these procedures every week. And I do that in different hospitals. Primarily, I'm doing that at Flagler Hospital in St. Augustine. We've got a very new, good technology there. We got a very evolving, great team there, as well as we've done at the Memorial Hospital in Jacksonville as well. So we work around the patient's comfort, but we do that at different places, different hospitals, and we take every patient very individually, treat them, tailor the treatment based on what the patient wants.
Dr. Pabbi, you have covered, in the amount time we have, a varied topics of symptoms, presentations, risk factors, touched about stroke awareness. I think the community is very deeply appreciative of awareness is the first thing before recognition and treatment. A question has come up which says, because we've been dealing with stress and as a highlight, and this is a wellness weekend, and we are promoting wellness, is stress associated with AFib, Dr. Pabbi?
Absolutely. There's no question about it. Like Amit said, I believe in very holistic approach on a patient, because you got to treat the patient as a whole. And stress is a very, very common trigger factors for atrial fibrillation. Stress is not just for AFib, but for every heart condition. And like you talked about the Takotsubo before, the stress is definitely a trigger factor for AFib. And stress doesn't have to be a mental stress. It could be a mental stress. It could be a physical stress. If you have a fight with your husband, or you have an argument, or you're dealing with some your parents' condition or financial situation or job stress, or even these days being stuck in a COVID or pandemic, it can definitely aggravate the atrial fibrillation and it can provoke it. So the best way is definitely, like you mentioned, yoga, meditations, healthy lifestyle, go out for walks, those things have to bring the AFib levels under control.
We have a couple more minutes, Dr. Pabbi. a question has come up. Does uric acid level inflammation have any effect on heart health, AFib?
Nice question. Uric acid level, not most of the time what we call a hyperuricemia was associated with accumulation of the uric acid. Mostly it accumulates in the joints, can lead to the gout flare up and stuff. On the old time, we used to call it the disease of the kings, where, it was the condition.
Rich diet.
Right. Yeah, uric acid directly does not affect the AFib.
Okay.
So indirectly, whether it can affect the other comorbid condition, because you get the uric acid high levels, now you get the joint pains, and you may not be able to get up and walk. That can lead to weight gain, can lead to the inactivity. That can provoke AFib, yes, but not directly. Uric acid may not be able to cause the symptoms.
Great. And again, I thank you, Dr. Pabbi. You've covered varied topics on behalf of First Coast Heart and Vascular and in joint collaboration with Indo-US. We've covered awareness, the main reason, topics, presentation. As Dr. Pabbi said, he's one of the main electrophysiologists who's been serving Jacksonville community since last 15 years, if I'm not mistaken, at least. And he's been there doing this for more than 20 plus, specifically in electrophysiology before that. And he's available in St. John County, Duval, Clay County, and all over. And like I said, not only specifically electrophysiologist, he deals with the patient as first, identifies the root problem. And we thank you so much for your time, Dr. Pabbi. Any take-home 2 messages you would like in your topic, Dr. Pabbi?
Yeah, absolutely. Take home 2 messages for atrial fibrillation. Like I said, be aware. That's the main thing. Don't ignore any symptoms, whether the symptoms are as mild as just the palpitations or irregular heartbeat. Go seek a help. Go talk to your doctor. Ask anybody. Doesn't have to be us, but go seek a physician. Get some help. Get it checked out. And or stroke is a very disabling for many people. We don't want people's life getting affected. So healthy lifestyle, watch your diet, exercise, and those are my main 2 points. Be aware of these things. And I really appreciate Indo-US Chamber as well as Dr. Idre in taking this time and coordinating things. I think this is one of the best things we've done for the community, and I was glad to be a part of it.
A lot of streaming is coming up, Dr. Pabbi. We appreciate deeply the time you've taken. And now we'll be inviting Dr. Hayes, our current president of First Coast Heart and Vascular. We've, like they say, we've kept one of the best for the last, as the adage saying goes. Pleasure and welcome Dr. Kevin Hayes, and who's one of our most premier non-invasive cardiology specialists. And a little bit background. Welcome, Dr. Hayes.
Good afternoon.
Good afternoon. And a little bit background of Dr. Hayes. He's been in the community since more than 15 plus years, serving Duval and St. John and even Clay County areas. And he's so eminently trained, a background from Johns Hopkins, Sinai, and great background with so overt, well-trained, and he sees patient as a holistic patient first. He'll be talking to us about heart failure and in general, cardiovascular health. Without further ado, Dr. Hayes, we'll keep it like a town hall format, and whenever you want, we'll ask more questions, Dr. Hayes.
Good. Well, absolutely. And, thank you for putting this together, Dr. Bedri. I think this is a great format to provide some information and certainly have time to ask questions as well. The topic I'll be speaking about today is congestive heart failure, some topic that most people have heard of before. Congestive heart failure is still the most common, what we call diagnostic related group, or it's the majority of the why most Americans are admitted to the hospital. What congestive heart failure is pretty much just as it sounds. It's the failure of the heart to keep up with the body's demands. Some of the things that congestive heart failure can present with are like anything else with a pump that isn't working real well. The fluid can build up in the legs and the abdomen and eventually the lungs. So one of the first signs of congestive heart failure is when you notice some swelling in the ankles. Okay. Next thing can be abdominal fullness. And one of the more common symptoms where we pick up congestive heart failure is shortness of breath when you exert yourself. The reason why this is so serious is it means that the fluid that is normally pumped forward by the heart out of the lungs can no longer do that. And fluid actually starts building back up into your lungs, which makes it very difficult to breathe.
Mm-hmm.
This process can take months to sometimes years, and at times it can happen overnight. So again, when the primary three symptoms, and usually the ones we get the most attention are, like I said, the swelling around the ankles or the legs, particularly as it comes up the calf, signs of abdominal fullness or bloating, and also probably the most common is shortness of breath when you start exerting yourself.
And Dr. Hayes, would you say what are the top risk factors for heart failure?
Sure. Well, I'll take a step back, and there's two different types of heart failure. Mm-hmm. There's one type of heart failure where the heart pump itself is damaged. Mm-hmm. That's what we call systolic heart failure. There's another type of heart failure where the heart is still pumping okay, but it's losing its performance. That's called diastolic heart failure.
Okay.
The most common conditions that can cause either one of these heart failures, both directly and indirectly, is coronary artery disease or having a history of a heart attack. What happens with the heart attack is the pump becomes damaged because it didn't receive enough blood flow, and that's due to cloggages in the arteries of the heart. And that's why we watch things like cholesterol and diet and managing your diabetes, is to prevent those plaques from forming, ultimately closing off or causing a heart attack, and therefore usually irreparably damaging the heart for the rest of your life.
Okay.
The other type of heart failure is what we call diastolic heart failure. And I usually like to use an analogy of an old rubber band. Normally, if you pull a rubber band back and you let it go forward, it bounces back and sometimes can go across the room. However, when things like hypertension, some infectious diseases, some actually forms of almost a cancer can cause that heart to become stiff. And when it becomes stiff, it doesn't spring back as much. And that can also lead to heart failure, although the heart itself has not been irreparably damaged.
Well, that's well put. And I think that analogy is so good. I'm going to start using it for my patients. So we've covered kind of short, succinct presentations, symptoms, and etiologies. What would you say are the prominent diagnostic modalities for diagnosing?
Sure. There's two common modalities we use with congestive heart failure. The first one is a echocardiogram. That's a sonogram of the heart. Universally, that's probably the most common tool we use to assess if a patient has heart failure or is at risk of heart failure. The sonogram of the heart is pretty much what it sounds. There's a small plastic probe put on the outside of the chest, and we take probably anywhere between 40 to 50 different pictures of the heart. We get some information about the heart valves, but overall it kind of tells us how the heart is pumping. A lot of people become alarmed when I use the term ejection fraction. Mm-hmm. Ejection fraction is the percentage of blood that is pumped out of the main pumping chamber of the heart. When I tell somebody their ejection fraction is 50%, they become very concerned and think that the heart's only working half time. Mm-hmm. That is not necessarily the case at all. A normal pumping function or ejection fraction of the heart is between 55 to 70%. So 100% of the heart pumping is not normal. In fact, that's considered abnormal. Usually start to get more concerned when the ejection fraction gets below 50%, is when we have to really start looking to see what else is going on. Maybe there's some blockages forming. Mm-hmm. Maybe the blood pressure has been really high. Maybe the heart has been damaged by infectious disease, and certainly COVID is in that group.
Yeah.
COVID itself can cause heart failure. When you start to talk about when the heart pumping starts to get less than 35 and it's maintained there for several months, that's when things really get serious, and we have to start talking to things like pacemakers, implantable defibrillators. And when you start to get to the 20% and below range, that's when you're talking things like implantable heart pumps and transplant.
Great. So I think that's very well put. And certainly since our audience is more of a non-medical, and you've done very well in simplifying it. A question came about saying that is heart failure hereditary? My father has heart failure. Will I get heart failure?
Sure. There are some types of heart failure that can be inherited. It's fairly rare when you compare to the type of heart failure that we deal with on a regular basis. One of the forms of heart failure, in a way, that can be inherited is the disease process called hypertrophic cardiomyopathy.
Okay.
And that's usually in the news when particularly like a young athlete suddenly passes out or unfortunately passes away by performing vigorous exercise. That's a disease process where the heart becomes irregularly shaped and thickened, and eventually the pumping can go down. And that can be a form of heart failure that's inherited. There are some other rare ones that can be inherited as well. But when you look at the overall causes of heart failure, those are extremely rare.
Okay. A question arised. It's more of a two-pronged question, perhaps a little digressing, but we'll talk. Can cholesterol increase cause heart failure? If so, how can it be reduced?
Sure. Well, I think cholesterol can cause heart failure indirectly in a way.
Okay.
Heart failure can cause blockages in the arteries of the heart called the coronary arteries, and leads to the most common type of heart failure is that if those blockages become severe or result in an actual heart attack when they get completely occluded, then again, that section of the heart that is fed by those arteries is usually damaged irreparably.
Okay.
Some people after a heart attack may have residual symptoms as the ones we talked about, such as swelling the legs or difficulty breathing, particularly when you exert yourself. So in a way, yeah, bad cholesterol can ultimately lead to heart failure, but it's usually the mechanism of causing an actual heart attack.
Okay. And more of a question is diagnostic modalities of echocardiogram. Is there a particular age where I can ask my doctor or come to you and start requesting an echocardiogram? If so, as a part of screening?
Sure. There's as of right now, we don't just usually check an echocardiogram just to be safe. Now, however, there are a number of reasons which are extremely common where we usually do get an echocardiogram performed. Anytime the EKG, which is a simple 12-lead EKG where they put stickers on your chest and check that, if that's abnormal, that would probably warrant an echocardiogram. The next thing is if we think that blood pressure has been under very poor control for a while and you're having symptoms from that, or if you're on multiple blood pressure medications, that would be a reason to get an echocardiogram as well.
Okay.
Some of the other reasons you would normally echocardiogram, which you and I see all the time, is if you come to your doctor and you complain of symptoms of shortness of breath, particularly with exertion, swelling in the legs. And one thing that a lot of people don't realize is one of the first signs of heart failure can actually be weight gain. Now, I know during the holidays, we all tend to put on a few pounds. However, with heart failure, it's almost impossible for you to gain 10 to 15 pounds from eating too much. You would have to dedicate your entire week to eating 24/7 to gain that much weight from calories, and it would take at least a few weeks to do that. Whereas patients, when they have undiagnosed congestive heart failure, can easily gain 10 pounds in a matter of 4 or 5 days. I
see. Great. And keeping the same format, a lot of feedbacks and buzzback is coming back, Dr. Hayes. And a lot of good information is coming along. A question came along, which I think you and me have seen in the clinic. I'll repeat it verbatim. I went on a cruise, my legs swelled up. I came back. My doctor told me I have possible heart failure and used the term diastolic heart failure. Can you tell me a little bit about it?
Yeah, a diastolic heart failure is one of the second most common type of heart failure. That's where the efficacy or the efficiency of the heart pump cannot keep up with the body's demands. In contrast to the other type where the heart is permanently damaged, usually in diastolic heart failure, if we get to it early enough, the damage is not irreparable. What happens with diastolic heart failure, if, for instance, your blood pressure is high, you go on a cruise, consume copious amounts of salt and fluid, then all that fluid kind of stays in the body, and the heart can't keep up enough to pump it to the kidneys so you can urinate it out. A lot of times, diastolic heart failure is caused by poorly controlled hypertension. And with regards to the echocardiogram, we can actually measure the thickness of the heart walls. And a lot of people think that the heart is a muscle, so if it's bigger, it's going to get stronger. With the heart, that's kind of the opposite. The thicker the muscle is in the heart, then usually the heart pumping starts to lose that elasticity that we spoke about to begin with.
Yes.
And that can ultimately lead to heart failure with fluid retention, hence the swelling in the legs.
Okay. A question is very pertinent to our times. I was diagnosed with COVID,
Sure.
and what can I do to limit my heart failure, and can I get an echocardiogram?
Yeah, I think that's that's a very pertinent question, especially in these times. And Amit, as you realize, this COVID has kind of thrown us some curveballs, especially in the cardiac realm. We've seen patients that have had acute heart failure, and their echocardiograms, when we perform them in the hospital with COVID,
Yeah.
the volume can be acutely lower, and they would need medications to help support the heart as they get through the illness. But we're also finding sometimes even weeks and months out, unfortunately, if you have COVID, you probably feel like you have a flu for a few days, and hopefully things went well. But a lot of patients come back even weeks and months into recovery and say, I'm still tired. I still feel very fatigued. I still get short of breath when I try to go to the gym. And I have a very low threshold for checking an echocardiogram in those patients. So if anybody out there is experiencing those symptoms, after probably an x-ray, I think a sonogram or an echocardiogram would be the next place to start.
Yeah.
And then, unfortunately, as you are well aware, that can happen, again, weeks and months after a negative test or that you recovered from COVID.
Yeah, well put. Thanks, Kev. Question is there any modalities? I know it's probably digressing, but diastolic heart failure, and in fact, it's a most recent question. You've explained it very well. I understand what is diastolic heart failure. Thank you. And can this condition be reversed by lifestyle change or any medication?
Well, yes and no. The diastolic heart failure, when we talked about the thickness of that muscle, once it becomes very advanced, it's kind of hard to go backwards in that. So it not necessarily can be reversed, but certainly we can do other things to modify it to promote cardiovascular health and fitness. So I don't think it's ever too late to try to adopt a heart healthy lifestyle.
Great.
A lot of times when the heart failure, diastolic heart failure, is caused by hypertension, then if you kind of get to it early enough, there's no set time as far as years. If the heart starts to undergo what we call remodeling, or kind of the thickening of the heart, then if we do things like lose weight and diet and exercise and keep that blood pressure under very strict control, sometimes that thickness of the heart muscle can improve.
Okay.
So, yeah, once you start to have the symptoms of diastolic heart failure and the thickening of the heart begins, it's of critical importance to make some healthy lifestyle changes to get that blood pressure under control as soon as possible.
Okay, thank you. Are there any effects of high uric acid, inflammation, arthritis on heart failure?
At one point we thought there was some link or association between what's called hyperuricemia or high uric acid levels in the heart. I think when you have conditions that are ultimately due to high uric acid levels, such as gout, that you treat those conditions aggressively. And, as Dr. Pubby alluded to, high uric acid levels are associated with inflammation. So if those are actually causing symptoms, then you may want to speak to your doctor about getting those treated. And then there's a few different medications we can use to do that.
Great. A question pertinent to our current times is, I always see my grandmother admitted to hospital right after Thanksgiving or Christmas time. Christmas is coming up. What can I help her or help her reduce it?
Sure. That happens a lot around the times of the holidays. The reason being is typically during Thanksgiving and Christmas, you really consume a lot more salt and food and drink than you're used to. When the body consumes a lot of salt, it tends to retain water. And like anything else, the more water you have in the system, the more challenging it is for the heart to pump that volume out to the kidneys. So if you have borderline heart function, or if you have a tendency to go into heart failure, you come along these holidays, especially Thanksgiving, you have a huge meal, probably to the tune of 1,500 calories, and you put extra salt on the turkey, consume maybe some drink as well, and then your body has too much fluid and it doesn't know what to deal with it, and you end up going to the hospital because you can't breathe.
Right. Are there any go-to points you would say about reduction of cholesterol in general and reducing the risk of heart failure? Both are kind of digressing, varied topics, but cholesterol.
Yeah, in particular, I think cholesterol is keeping the cholesterol low is going to keep you from building up the blockages in the arteries of the heart. So much so when we have somebody who comes in, even if the blockages aren't severe and they have symptoms of heart failure, guidelines say that heart failure patients should be on a cholesterol medication, even if by normal standards, their cholesterol levels are okay. Again, if we want to make sure we're very aggressive about preventing once you have heart failure and, you have a heart attack on top of that can make a bad problem worse. So you usually become very aggressive about keeping that cholesterol extremely low, particularly in patients with heart failure.
All right. What is a good, I've been told my good cholesterol is okay and my bad cholesterol is high. What does that mean? And are there any numbers you would recommend, Dr. Hayes?
Yeah, I get this question quite a bit. And talk about the good and bad cholesterol, and we still think that holds true. A lot of the major studies have indicated that particularly if you have heart disease or heart failure, that your bad cholesterol, what's called your LDL, normally on a blood panel, anything between 100 to 129 is considered technically normal. Anything above 130 would be flagged as abnormal in most primary physician offices. But with heart failure and coronary artery disease, we want to keep that bad cholesterol, try to get less than 70, or certainly get pretty close to that number. Mm-hmm. And that usually requires medication. Most commonly, the medication is known as statins. Mm-hmm. So I think for most healthy adults, we usually shoot for a goal of, less than 129, or 129 or less is considered good. But depending on what risk factors you have, if you have a family history of heart disease, sometimes we push that number to less than 100. And then if you have severe heart disease or heart failure, we try to get that number less than 70.
Yeah.
And as far as the good cholesterol goes, that one's been a little tough to deal with. We certainly think that having very low cholesterol is one of the more common things that you can have passed on from your parents. Mm-hmm. And that is associated with the higher risk of coronary artery disease. And we don't really have any great medications that can increase that number significantly. Now, some of the statin medications that are commonly prescribed can increase that number a little bit. Mm-hmm. But as far as finding any magic pill that really gets that number cranked up, we haven't found a real effective one yet. There have been many tried. And I think that's right now is a hot topic of research.
Great. So we've talked in a varied topics, Dr. Hayes. We talked about symptoms, presentations. Are there any top 2 messages or top 3 messages you would help us to take home?
Yeah, sure. With regards particularly to congestive heart failure, don't ignore symptoms. A lot of times things like swelling in the leg and shortness of breath with exertion are very common symptoms. A lot of times they aren't heart failure, but that's something you certainly don't want to miss. So particularly the swelling in the ankles, the weight gain, and the shortness of breath with exertion have a very low threshold for getting to your physician and speaking with them about that. Because as you know, the sooner we get to heart failure and the quicker we can treat it, and we have tremendous medications and devices that can prevent things from getting worse. But the earlier we know about it, the more options we have.
Got it. It's a little bit of an offbeat question, but in general, what are the thoughts on statins? Do they cause any heart failure?
Well, there are case reports of that. It's not really widely recognized. Statins themselves can cause what's called a myopathy, mm-hmm. Which is usually felt in some of the arms and the legs and the more proximal muscles. That has been fairly well established. It's pretty rare. I mean, people can have aches and pains after taking statins, but by the time it actually causes a myopathy or muscle breakdown, it is a known side effect, but that's extremely rare. What is even more rare is whether or not statins themselves can actually cause a cardiomyopathy. That is exceedingly rare. And
great. And I think the take-home messages, what you mentioned, are right off the bat, were very, very pertinent points. And one of the last question is, if medications don't work and have ongoing symptoms, are there any surgical options? I think you alluded with pacemakers, defibrillators.
Yeah, sure. If the once the heart gets so bad, despite having what's called maximal medical therapy, a cardiac prudent diet, try to get regular activity, there are a number of things we can do to help the heart get better. The first one is what's called an implantable defibrillator. Sometimes if we can fine tune the electrical system of the heart, the pumping can get better. And also the defibrillator's there if the heart starts to fail and actually tries to stop, it can kind of shock you back to life.
Yeah.
I'll go back a few years. The former Vice President Cheney had blockages in arteries so bad that he had severe heart failure. And as you know, he ultimately went on to get what's called an LVAD, which is a system where it's they plug tubes into the heart inside you, and it's connected to a small device that you carry around in a little pack. And that actually acts as an external pump, it helps pump your blood through your body. And those are usually done at a specialized center. So we do have quite a number of different options that we can use both on a temporary basis and a more permanent basis to actually help the heart pump itself.
Great. Dr. Hayes, you've spent a very valuable time over the weekend, and we've touched home as a summary. We've discussed about salt, hypertension, women's heart and disease, irregular heart rate, cholesterol, and heart failure, varied symptomatology, presentations. Where do you practice, and how can we get in touch with you?
Sure. I practice in Jacksonville, Florida, right off of University Boulevard. You can provide all my contact information. We're on the website at firstcoastheart.com. We are accepting new patients. So, anytime you have some of these symptoms that are concerning, my biggest advice is please get to us early. I think there's a lot of neat technology that we see every day, but the sooner we know about these things, the better.
That's well put, especially during COVID times. We should not put away the common symptoms.
Absolutely not.
Yeah. Thank you so much for your valuable time. On behalf of First Coast and Heart and Vascular, Dr. Hayes.
Sure. And thank you very much, Dr. Bedri. And we also thank the Indo-US Chamber as well. We appreciate it. Have a good day.
Yeah. Have a good rest of the weekend. Thank you, everybody. You all have a wonderful rest of the weekend. And as a summary, we've done quite a varied presentation with an innumerable topics discussed. And this is a day one among our wellness weekend. And we've discussed primarily today about heart health tips. They were digressing topics, but I hope we kept it as non-medical as possible for our regular audience. The take-home message is what I've taken. I'll put it out there from our varied preeminent speakers is wellness is a very, very important tool. Stress management and ability to understand symptoms, and more importantly, awareness of what those symptoms are. As Dr. Hayes just mentioned, going to the doctor at the right time. As Dr. Kaveti mentioned, women and heart disease, the way they present are very, very different. As Dr. Pubby mentioned, irregular heart rate awareness, stroke reduction is very important. And as how initial speaker, Dr. Curry, well put, the ability to understand myths and the ability to understand what our food products are and what the content is. And looking at the next time you look at the label, think about it, learn about it. And for everything else, we at First Coast Heart and Vascular are always there. We are, like Dr. Hayes said, we are available at firstcoastheart.com, and we serve Duval, St. John's, Clay County, and we thank Indo-US Chamber of Commerce, Northeast Florida, the entire team. And stay tuned for the day 2 for the other aspects of wellness, which is mental health, spiritual health, non-allopathic, which in collaboration with allopathy is also important as a holistic modality. And we all thank you for tuning into us, and have a wonderful rest of the weekend with your family. Have a blessed day.